And now we're moving to a panel discussion. And our discussants today, one is Jeffrey Duchin, who is the health officer and chief of communicable disease epidemiology and immunization section for public health in Seattle and King County. And in that position, of course, he was one of the first public health officials in the United States to face COVID and to have deaths in the United States. So, you know, it was more than a year ago, or I guess right around a year ago, when he was starting to deal with that. And even in the worst parts of the pandemic, he was always very generous and clear with talking to the public and talking to reporters. He answered a lot of questions back then. You'll see him quoted in a lot of places, and he really kind of helped communicate to the public that this is a serious disease, and here's what we know, here's what we're learning. So he was very valuable to public communication at that point, in addition to doing all the public health work. He's also a professor of medicine at University of Washington, Seattle, and he serves on the CDC's Centers for Disease Control and Prevention's Board of Scientific Counselors and the Advisory Committee on Immunization Practices, and is on the board of directors of the Infectious Disease Society of America. So he's with us today. Thank you so much for coming. And then we also are very fortunate to have Marcos Espinal, who is the director of the Department of Communicable Diseases and Health Analysis at the Pan American Health Organization, or PAHO, which is the regional office of the World Health Organization for the Americas. So before joining PAHO, he served as executive secretary of the World Health Organization's Stop TB Partnership, which is a global movement aiming at the elimination of TB as a public health problem. He has work experience all over. He's had positions in the Ministry of Health of the Dominican Republic and the National Center for Research on Maternal and Child Health in the New York City Public Health Department. So we're really grateful to both of you for coming today. And thank you for Emily for staying to be part of this panel discussion. And to open it up, I'd just like to ask Jeff and Marcos, you know, as Emily said, the COVID has been, it's a global pandemic, but it's a local phenomenon. And how does her description of the syndemic nature of it, you know, how did you see that? How does that relate to what you experienced in the past year with the pandemic? And maybe Jeff can go first if you're ready.
Okay, well, thank you. It's a pleasure to be here, and I look forward to this discussion. It's a very rich and complex framework. Let me begin just by briefly describing our outbreak, and because it's not, you know, homogeneous. There's a variety of our county is very diverse, and our outbreak started over a year ago in February in long-term care facilities. This is where the outbreak erupted. Mostly white elderly residents were impacted, as well as the staff of the facilities, which were primarily made up of people of color. And after a great deal of morbidity and mortality in that older age group, our first wave subsided, and the second wave came over the summer, which was something that was more commonly experienced throughout the US, with the predominant transmission among younger adults. And that was followed by a third large wave recently in the fall and winter, which was responsible for about 2/3 of our cases and half of our deaths and hospitalizations. And the outbreak evolved to disproportionately impact people of color. So our case, our hospitalization, and our death rates are higher in various race, ethnicity groups other than white. So Black, Hispanic, Native Hawaiian, Pacific Islander, American Indian, Alaska Native, all were having disproportionate rates of disease. We also recognized a few things early on related to the potential for asymptomatic transmission, potential for super spreader events. All of these things sort of went against what was the common dogma at the time of, you know, early on spread from people after symptoms developed, and and droplet transmission as the primary mode, which we're now coming to realize is more of an aerosol airborne disease. Now, overlaid on that, we know in our county that life expectancy varies by up to 13 years according to the neighborhood in which you live. And also correlating with those same neighborhoods that have poor life expectancy are things like poor housing conditions, tobacco use, frequent mental distress, adverse childhood experiences, lack of physical activity, obesity, diabetes, preventable hospitalizations. And it also correlates with household income, lack educational level, and proportion of people of color. And our COVID-19 case, hospitalization, and death rates fall in those same patterns. So the same communities that were previously recognized to experience the health disparities related to these other underlying conditions and chronic diseases that are the primary causes of death and disability in the US are also the communities that suffer disproportionately due to COVID. So that said, you can see a lot of potential for applying both the underlying and the COVID outbreak, the framework of syndemics to the underlying conditions and the COVID outbreak. I think one of the challenges for me is that we really don't understand the biological sequelae or the pathophysiology of COVID-19 completely yet. And that's, this fundamental issue of how it interacts with other diseases, I think, is yet to be determined. Clearly, the social and the economic and the other systemic racism, all these pre-existing factors that exacerbate both the underlying causes of death, pre-COVID and COVID morbidity, mortality are there. The thing that I'm a little bit struggling with at this point is how all this, will relate to what we learn about, the disease itself, its pathophysiology, what diseases it may interact with, the long COVID situation, that's and their behavioral health issues, because there are clearly a lot of behavioral health issues. Two other things I'll just mention quickly that I think are relevant in the context of syndemic is that in September of 2020, we had a wildfire smoke event that was demonstrated a cascading impact of climate change that drove people with COVID-19 indoors and closing their doors and windows, which is exactly what you ask people not to do during the COVID epidemic, which is to spend as much time outdoors and to keep their doors and windows open. So that was one interesting challenge that occurred. And let's see, the other one the other one just flew out of my head. So I'm sure it'll come back during the discussion. But are those helpful as introductory remarks, or is there something else that you'd like me to focus on?
No, I think so. I think we'll come back to a lot of the issues that you raised, but that gives us a nice sort of orientation of how you experienced the pandemic. And Marcos, could you tell us about how you've been experiencing the pandemic this year and beyond the year, and how you're seeing the syndemic nature of it emerge?
Well, I think I want to agree with Emily. Thank you. I want to agree with Emily with it is local, actually. When the Brazil outbreak came out, people were generalizing about the whole of Brazil, but there were communities in Brazil that were not having COVID outbreak or cases of COVID, and there were communities that were heavily impacted. And in our weekly press events in PAHO, we always talk about we're not dealing with a public health problem only, we're dealing with economic and social problem also. And the best example to quote is what is happening in Manaus in Brazil among indigenous people. One of the highest mortalities in the world. But guess what? Indigenous people is one of the most neglected population groups living in situation of vulnerability, and in Latin America. So, and we have seen in the news how mortality has ravaged the Manaus communities in the Amazon. So it is definitely an issue coupled with social and pressing economic issues also. Just a few days ago, we all look at that study that came out in the news about in most the highest mortality related to COVID, it's in countries where 50% of the population is obese or has high rates of obesity, and that's very telling. And on the contrary, countries like Japan, Thailand, Vietnam, with low mortality rates on COVID. So I think this is not a new thing. One of the diseases that has been very close to the syndemic concept is TB. You know, countries that made progress in TB control, and TB has been fooling us for 4,000 years, is because they have been making progress also in social and economic developments. And we look at TB, it's a disease of the poor, it's a disease of overcrowding, it's a disease of poor housing. And this is, and Emily just mentioned all of this, you know, overcrowding, poor quality. How can people do social distance when they live in a small room that breathing is problematic? And I bring a famous philosopher in Paris says that social distance is a concept for the rich and famous, because not even in Saint Denis, the famous poor neighborhood in Paris, can we experience social distance. So it's clear we need a systemic approach to try to face this. We have seen it in Latin America every day. And in fact, Latin America and the Caribbean is the region, probably the highest region in terms of inequality in the world. When you look at Asia, we talk about demographic explosion. Or to Africa, we talk about a lot of poverty. But in Latin America, countries are growing economically, but the wealth is not distributed fairly among the people. So, and we see a lot of inequalities. Water and sanitation. You know, how can countries combat COVID if people don't have access to wash their hands? This is a simple issue, and while in Latin America and the Caribbean, countries have access to pipe water, that is different to say they have full coverage of high access to quality water, which is another thing. So in my view, if we want to address this issue of COVID as only a public health problem, is not the right approach. We have to couple with economic measures and social development measures. So, and when you talk about social determinants, and in PAHO, we've been producing norms and advice to countries in the Americas how to deal with this. And the other issue is, and I pause here, it's mental health, which is a massive issue. I mean, you have to realize the fatigue that is out there. And people just saw a few days ago, Italy is going to lockdown again. It is a huge problem for people and mental health is a massive issue that we need to take into account. Let me pause here. Thank you.
Thank you very much. And thank you for bringing up TB, tuberculosis, and as Emily did, she brought up diabetes and AIDS. I think for any of the three of you, are there interventions that worked for for tuberculosis, for AIDS, for diabetes, in addition to the ones that Emily already told us about, that seem like they might be relevant and something that could be urgently done for the COVID syndemic?
If I may add, Laura, I think the most important intervention, and there are several possible, it's engagement of the community. If we engage the community and the community is empowered to address the issue along with the national authorities and the local authorities, then we can see results faster, because the community cares about their own people. And if we come as outsiders only and impose decisions and actions, it will not work. It will work. It might work for a few days, but we need to make sure the community is empowered to make sure it happens. The other thing is the will of the authorities, that to make sure they are open and transparent to embrace other sectors into this. That is not my territory, and not that I need to do. It's the famous concept also of the One Health issue that we've been talking in the past, that intersectoriality, work as a team, and to make sure we provide potential solutions for this. And finally, development. Money is always an issue, and we cannot deny that. But development goes in line on not only with health development, but also social development and economic development.
If I can follow up on Marcos's comments about engaging community, I wholeheartedly agree. But one of the challenges that we face is that whenever there's a public health disaster, it becomes quite apparent that these underlying predispositions, structural issues, inequities that have been long-standing on multiple fronts, economic, social, and biomedical, are predisposing certain people, disenfranchised populations, people of color, to higher rates of disease, morbidity, and mortality. And there's always a call to what can we do quickly to reverse this? And my experience tells me that it's not something that can be quickly reversed. I mean, this is a problem that requires a fundamental restructuring of how we think about health and equity, and a long-term engagement and investment. So, for example, we and many others have found that communities that are highest risk from COVID-19 are essential worker communities, people of color, as I mentioned, many times lower socioeconomic areas, and have a fundamental distrust of government, of the healthcare system for many reasons, are skeptical of messaging around social distancing, for example, for all the reasons that you just mentioned. They don't have the luxury, people have to work. They live in multi-generational households with smaller spaces where they buy their food and do their shopping, are less well-ventilated, crowded spaces, maybe can't take the precautions that more well-resourced communities can take. And trying to go in the middle of a public health emergency and address these issues is quite challenging. First of all, relationships take time to develop. Trust takes time to build. And the investments that are needed to allow people to be healthy with respect to economic investments and investments in access to healthcare and so on, are not things that can be reversed in the heat of a public health crisis, in my experience. So it's great for me to see this recognized again, but these fundamental, I think, challenges are recognized periodically whenever there's a global public health emergency. They were recognized during Ebola. They were recognized during Hurricane Katrina, you name it. So that's just one factor. The other thing I just wanted to briefly mention was, with respect to homelessness, the COVID-19 outbreak led to de-intensification of homeless shelters. It led to closure of lots of places where people living homeless get shelter during the day, where they might get access to restrooms, toilets, and water. And we've had outbreaks of GI, fecal oral diseases, I think in some measure related to the fact that access to water and sanitation has decreased as well for that population, during this crisis. And concomitantly, we're seeing a spike in overdoses, opioid overdoses, primarily fentanyl driven. And this is difficult to tease out from the pre-existing increasing overdose trends due to fentanyl, but we believe it's not unlikely that it was exacerbated by the stress of the outbreak.
I had a response to the TB question. Initially when you asked the question about TB, I thought about direct observed therapy short term and how, for TB, there's so much engagement with people who have the infection and caring for them throughout the treatment. TB care is really makes you feel really sick. So people don't want to take it and they don't want to follow it. And I was thinking about things I've read elsewhere and things I've seen in clinics I've worked around the world. But then I actually thought about my husband who was on TB. He had TB he's a global health professor too. And he was infected and he had latent TB, but they changed the policy in the US that actually everyone with latent TB actually has to treatment now, although it didn't used to be the case. So he had to get treatment. And I have to say that he was followed up with more than anything I have ever seen in the United States. And this was when we were living in DC, so, right when we actually moved here 8 years ago. And he was followed up with weekly. And when he couldn't actually go to the clinic, they came to a street away from our house and delivered the medication and made sure that he took it. And I thought that was profound to see, even in the US, we can do this. We can meet people where they are. We can provide better care. We can work in communities in profoundly different ways than we do. And I thought that was really interesting. So I think that your suggestion of the TB model is one we can build on, is an important one. And another thing, I haven't lived much with illness, but I have had 2 kids, one in the UK and one in the US. And I have to say the differences in care I provided in the UK and the US are so profound. And my encouragement of the US needing to think about home visits could not be more important. I had a lot of complications with both, actually, the first one the most, but I had someone who came to my house every single day for 3 weeks until I was discharged in the UK every single day. And my daughter probably would have died if they had not done that. And in the US, I had my daughter who didn't have as many problems, but I didn't see a doctor for 2 weeks. No one called me. No one checked in on me. And if I was a first-time mother, I can see how challenging I would have found that, especially if we had the experiences of the first child. So I have to say that, there are things we can do that are not complicated and really can promote, especially when we think of maternal mortality among Black mothers and how different that is. A lot of that is because we do not care for people as whole people. And I think that there are simple community-based strategies that we can do to really face these tragic inequalities head on. And so I think that COVID-19 has produced some interesting new technologies. I'm contacted constantly about my symptoms by different things I've signed up for, but there are new tech modalities that we can take forward to apply to other conditions and to start to get at some of these inequities that we see.
Emily, I would just add that, we have models in the US that work. The Nurse-Family Partnership is an amazing model that supports families who are largely Medicaid eligible, and provides the mother prenatal through delivery with the type of support that you received in England. And we have had similar models out here around asthma care in low-income communities that have shown benefit. One of the challenges we're seeing is, developing the funding model that will allow these to be incorporated into, routine care. We really strongly believe that community health worker model is very valuable for a wide range of chronic health conditions, diabetes, mental health, you name it, and all these interrelated disease management challenges, particularly with behavioral health. But it's very difficult to be reimbursed if you're a provider for these types of services.
Yeah, so just let me add briefly. In some of the countries, for instance, the issue is not probably similar issues of reimbursement and health insurance, but the good example of Costa Rica, for instance, who has the concept of universal health. When the pandemic started, what they did immediately was to mobilize an army of health workers and volunteers to assign them neighborhoods. So they had to visit every COVID patient every week or every other week to make sure the patient was eating properly, to make sure it was not without symptoms, not with symptoms, or to avoid going into a crowded hospital or things like that. So this thing works because people also feel confident when they see someone coming and knocking the door. How are you feeling today? Are you taking on your medicines? What can I do for you? These are simple things in agreement with Emily that can be done. So the other thing that I think it's important is that the misinformation and the fake news, fighting those is very critical. And it's up to the national and local authorities to keep educating the population and the communities, because there is so much information out there that, we don't have to refer, but we'll remember several of those. So it is important because that will confuse people, and mainly in countries with low literacy or that they don't have different countries to the States or the UK, for instance. So this is major if fighting the miscommunication and the fake news. It's something that we all need to take into account. We in PAHO has 9 pillars recommending to the countries to address this issue. But again, we should not see it as isolated, as only a public health problem.
Yeah, and with the misinformation, just to address everyone who's with us today in the audience, there's misinformation research is one of the hot subjects in science right now because there's so much to study, even before the pandemic, but especially during the pandemic. And I think one of the findings that is very robust, comes out again and again in different interventions, is that personal relationships make such a difference. So if any of you are, have colleagues, friends, family who are exposed to misinformation, especially if they're sharing it, like, please, everyone, feel empowered to call that out, to correct it, to explain, where it came from, what's actually true, and to do it with compassion. But it really seems like the countries obviously need to do it, and primarily need to stop sharing misinformation for the politicians who've been doing that. But it really is on all of us to share real information, especially as the vaccine rollout is seeing like an amplification of all the anti-vaxxer nonsense. So thanks to everybody for caring about that and trying to do it right. So we've talked about great stuff. Do you all ever, as public health experts, do you during the course of the pandemic, have you felt like saying, we told you so, we told you this was coming? And, of course that, that's not even satisfying. There's not much you can do with that, but do you see ways to translate that, we told you this was coming, to, and listen to us now? Like, do you feel like this is an opportunity to get more attention for the need to address some of the endemic underpinnings of this pandemic and other health crises?
Well, this is Jeff. I'll start. It is a little bit like Groundhog Day. After every major emerging event, we realize that our public health infrastructure is unprepared and inadequate, and we realize the challenges of our information systems, of the pre-existing vulnerabilities and the need to address them to achieve, better equity and health across populations during these events. And, the history of public health is these episodic investments, post-crisis, and then regression to level of underfunding. And what that means is basically agencies and stakeholders, bring on staff, hire them, train them, and then let them go. And it's a very challenging thing, obviously, for community. We talk about community, building and the importance of investing in community. But when you're, facilitating organization, which is largely the public health system, is constantly, being underfunded or funded, and then programs and relationships are built and then they wither because funding is gone, the investment can no longer be made. It becomes very challenging. I'm hopeful that people will learn the lessons from COVID-19, because clearly there are much worse pathogens out there that can create many more illnesses and deaths in a short time frame. that we need to be prepared for. We've certainly identified again and highlighted many of the vulnerabilities and gaps in our preparedness that can be addressed. But whether or not that will happen or not, I don't know. I certainly think that investing in the underlying health and well-being of our community will serve us well. But it's not an easy task. There's a lot to be done, and it's going to require serious political leadership at the highest levels of government.
I want to think people are taking notice of the situation, and we can move forward in a positive way and become less reactive and more proactive. Because that's what it is when we have a pandemic, H1N1, Zika, Ebola. I see signs that the world is taking note of that. The fact that the World Health Assembly is now put the machinery to start reviewing the international health regulations, it's a good sign. The fact that the G7 is now talking about One Health, it's also a good sign. And this is what it is. We should not promote the I told you so. I think the world knows. And I think the key issue is that this will continue. There will be more pandemics. There will be more outbreaks. The X factor, or we don't know. I mean, Peter Dassler is connected, and he knows probably about zoonotic diseases, and he was recently in China looking after this. So there's 60-70% of outbreak come from the animal, agriculture, human environment interface. Zoonotic diseases. We're dealing with something that is not going to stop. It's cycling, so we need to have better mechanism. We need to have less duplication. We need to maximize our own resources and make sure the systems in place propose better accountability, because that is one of the problems with some of the system is voluntary. It's I sign up, but I don't do it. So we need to make sure we make accountable countries that are not coping. But also we need to help those that cannot cope, because the world is not really, in terms of equality, is fair. It's not fair. So it's a complex issue, but the key issue is that this will continue, and we will have more outbreaks, these unknown diseases, and so on. So I'm hopeful the I told you so becomes a more proactive, better systems, better accountability and better monitoring and evaluation, use of the new virtual tools, real life data and so on, that allow us to fast track and to rapidly move into an incipient outbreak or something that we can stop from disseminating further.
Yeah, go ahead, Jeff.
I just have to say, as a public health person on the ground, I hate talking about COVID as if it's in the past tense. This outbreak is not done with us. And, the threat of the variant. First of all, we have a very substantial level of disease still happening. And the variants present a tremendous threat that, we still are not past. So it's great to talk about lessons learned, but I still think there's a lot more ahead of us with the current outbreak that we need to get through before we're going to have the full landscape of, what we went through and what we need to learn going forward.
Yeah, I just wanted to make a comment that I actually think there's different levels of I told you so's. And I think that the overarching lesson for public health and medical folks is that politics matter so much. And I think a lot of people in public health and medicine kind of overlook it and don't get involved in politics, or people say, I don't get political, but health is political. Illness is political, disease, where it goes, it's political. So I think this has been a lesson for the public health and medical community in such a profound way. So the three take homes, I think, are the international community, as Marco suggested, is people are really taking IHR seriously and really thinking about why are so few people implementing IHR and how do we make sure it's more expansive and it's more integrated at the national level. Another is looking at how the global health security agenda was dissolved in 2018. And in the US, we have some of the best experts in the world. I think the Global Health Security Index, US was ranked as one of the country most prepared for any sort of viral threat. And of course, we see that politics matter. And with the dissolution of the pandemic plans that my colleague Rebecca Katz carefully sculpted with others, one of the most frustrating things is that all the plans that were set in place were ignored. So, I mean, I told you so falls flat, because at the end of the day, politics trump science. Using that language, but politics undermine what we know and do. And without the, people really committed and the political level to what we know and do as scientists, nothing will happen. And then at the other side, the third level is I really think that kind of the reckoning of racial justice, economic justice, health justice at the community level is profound and really cultivating opportunities for rupture and rebirth in our country. And so I think some of the things that we're already seeing with the Biden administration, these kind of in the COVID relief bill, seeing the investments in early childhood, seeing investments and taking seriously minimum wage. These are small incremental steps that have consequences, positive potentially consequences. So I do think that there are lessons learned that are now being implemented. And these are all politics, but have implications for the extraordinary health inequities in our country.
Thank you.
Emily, we'd also add that, as Jennifer Nuzzo pointed out in a JAMA piece, the Global Health Security Index that found the U.S. best prepared of all our economic and OECD peers also found that we scored lowest or close to the bottom on trust in government and on access to healthcare and for our level of social support to our community. And we know that compared to our economic peers, we invest relatively little money in social well-being and social support for our people, and things like minimum wage and early childhood development. I think criminal justice is another piece of this that fits in. In King County here, we have a couple of initiatives, a big taxpayer-funded initiative, over $65 million a year to promote early childhood development, and it's broken down into prenatal, early childhood 0 to 5 and 5 to 18. And then a zero youth detention initiative, which is going to depopulate the jails of youth, incarcerated youth by 2025. So we're fortunate here that we have good political leadership, but I think this is, quite variable across the country. As you know, although we were one of the first communities to be hit by the COVID outbreak, we have among the lowest incidence rate and death rate compared to any other metropolitan region or large area in the country. And I think part of that, there are many reasons for that, some of which are beyond anyone's control, but I think part of that is that we did have good, cohesive and coordinated political leadership by our elected officials.
Great.
Laura, can I follow on that? Just short.
Sure.
Yeah. On the issue of criminal justice, COVID is a great example, this endemic relationship of COVID with prisons. It's just another great example. Several outbreaks of COVID-19 in prisons in Latin American countries has been reported. But also, TB, we're about to publish a study where we are seeing declines of TB in Latin America, but we are seeing increases of TB in prisons. Overcrowded, lack of space, breathing space. So these are related issues that they need to be addressed, and we are not going to eliminate TB one day if we want to. I'm not saying it's soon, but if we don't take into account these factors, determinants, it's not going to happen.
Great, thank you. So this has been the panel discussion portion. We'll continue panel-y discussion-y, but I do have a lot of questions from the audience, so I want to try to get to some of them. One is, we've seen around the world a lot, especially unfortunately in the United States, a lot of anti-Asian rhetoric, a lot of xenophobia, a lot of racism. And is this, would you say that this is part of the syndemic problem, and did this make the COVID pandemic and local outbreaks even worse? Is that something that's come clear from this syndemic? Yeah, and I assume the answer is yes, obviously, but is it? Is there anything you'd like to follow on about that to amplify, like how that inhibited the proper response or proper understanding at the beginning of the pandemic spread?
I can kind of answer this because I actually haven't looked at the data yet to show. So part of the interaction itself, like I think Asian American racism has been extraordinary in the US, and racism in the US is especially cruel compared to other countries. And so I imagine that affected some people wanting to report symptoms. I don't know. But when shame or racism, for example, and shame is imbued in that, becomes stigma, it's what becomes really harmful. So when it is imbued in structural inequality, I think it becomes especially harmful. So I definitely think it has been, but I can't talk about the processes because I haven't studied it. But as a social phenomenon, I think it probably has had profound impacts on how people experience and embody and carry with them the violence of that racism. But how that's imbued syndemically, I haven't worked out yet, specifically that case. But I think it's something that people will continue to really take up as those interactions, and as a scientist of syndemics, that's what I say. But it's such a shameful thing that's been experienced in the United States, but it's not surprising given our history.
Yeah, and just to add on to that, we recognized early on, even before our outbreak occurred here, stigmatization and racism occurring in our Asian American community here, which we have a significant population of Asian Americans in the Pacific Northwest. And we then did some community outreach, and the results are still being finalized. But one of the messages that we got was that this stigmatization really inhibits people from testing, wanting to learn their diagnosis, because it's a stigmatizing diagnosis, and further ostracizing, and also the implications on their ability to work and go about their activities in their lives once they receive the diagnosis. So I think there's a disincentive on many reasons to receive testing and care, but also there's other damage that's done by virtue of the stigmatization, and there's physical violence and verbal violence that happened, and there've been many episodes of this documented.
But I think it's happening in other countries also. Look at what's happening in Brazil, where even there is no agreement between the head of the government and state governors and so on. And one of the reasons Brazil has experienced high increases in several waves of COVID and mortality is, the spreading of shame, xenophobia, and so on, because Brazil also has a high population of Afro-descendants and also indigenous people. And when a very important person says, don't bother with COVID, it's nothing, or it's a flu, this is not an easy thing to say coming from an authority. So it's games historically are so fragile that anything could damage those games. And this is not new, we know that. the beginnings of HIV, the stigma, TB, stigmatizing disease for years and years. So I think it's proven that if we spread shame and xenophobia, it's going to affect negatively the impact on any approach you use to try to address the public health problem.
Great, thank you. So we have another question. It's directed at Emily, but I think Marcos and Jeff probably had things to say about this too. New Zealand is kind of a special case for a lot of reasons. Are there lessons from New Zealand that you think could be applied to the United States? We're obviously have a less isolated. We're not technically an island. Have a much larger population, so there's some structural issues that make it that maybe gave New Zealand an advantage. But what are some of the lessons from New Zealand that you think we could learn? Either in the United States or in other places such as Brazil, where there have been really terrible outbreaks?
Sure. I think that it's really interesting to think about leadership and policy. So on the leadership side, I would say that Ardern showed pretty charismatic and compassionate leadership, elevating and showing concern for people and your neighbors. And, I think one of the biggest challenges in the US, and I found this at the community level in the book I'm writing, is that, when you don't, as a leader, show compassion for your neighbors, that radiates throughout, or when you mock others, that radiates throughout the country and has profound implications. And her leadership, that she repeated the idea of trust and caring and taking this seriously and being collective again and again, almost every time she spoke. And that sort of leadership matters. And I do think that had an impact. On the other hand, she had really strong policy responses. She shut borders. We've never shut our borders. She shut borders, really intensive contact and tracing. I mean, every sort of policy that you should follow by the book, she did. And so it's a good example. And obviously, it's a very different context. What is it, a country of 5 million people? It's an island. You can shut that down pretty easily. It's totally different context. It's not comparable to the United States in that way, but it is an example of really following things by the book and shutting down an infection. So I think in that way, it is a fantastic example. Now, is that possible in the United States? Because of the some of the things that Jeff suggested on what the United States fails to do is have confidence in our leadership. There's such rugged individualism, this kind of settler mentality and individualistic cultural values and distrust of others and distrust of science and leadership. And, we are in an incredibly fractured society, politically, socially, economically, and that makes collective action hard. So on the one hand, I think that the lack of any national response in our country absolutely crippled the capability to response, and the utilization of state cooperation for political advancement by our president was really harmful and put blue and red states against each other. And if you were a Republican governor and didn't follow and promote personal responsibility, there were real consequences for you. So from the kind of national leadership at the time, so things have shifted. I think a lot of us feel the shift in the public health community with the new administration on how seriously things are being taken. And I definitely think that there is a shift across the states as well, but having no national strategy is what is so different from the New Zealand case as well.
I agree with all of that. And I think another fundamental difference and a huge gap in our national response was our inability to support people to comply with the recommended public health measures of isolation and quarantine, to give them adequate facilities, to if they couldn't do that in the home, and particularly for people who have large multi-generational households. We know that household transmission was our major mode of transmission, but many people, virtually everyone, quarantined within their own home or isolated within their own home. So we didn't have adequate options for people that, that were acceptable, and we didn't have the ability to support people economically to take the time off from their work, or to protect them from being fired from their job, in order to comply with isolation and quarantine. So it gets back to that issue of social support for people. And, I think that was a major gap in our national response, and a big difference between us and some of the more successful countries.
Yeah, thank you. So another question related to that, I think, is, could you speak to how, occupation, the type of work people are in, how is that considered a social factor involved in a syndemic? And, are there ways to make it less of a factor in a syndemic?
Well, I'll just start. There are clearly occupational groups that have been at high risk for COVID-19, particularly agricultural and other manufacturing, where workers are in close contact for prolonged periods in indoor air spaces. That sector, agriculture and manufacturing, are less white, more BIPOC, lower wage in general. And those risk factors are laid upon some of the other things that we've spoken about: the housing, home environment, multi-generational, many people in the same household, and the issues around workplace safety is a big one. As we learn more about airborne transmission and personal protective equipment that needs to be implemented in the workplace. These things are definitely drivers of both disparities and COVID transmission in the community. And the populations, again, at risk are the same ones that suffer disproportionately from a whole wide range of other adverse health conditions. So, your question is right on. It identifies another vulnerability in the population that is, disproportionate and inequitable across race and income in communities, and it requires a serious investment in resources and effort to do something about. Providing workers with leave, improving resources to improve the working environment. All these things, will be costly, and so there needs to be a tremendous amount of support for these things to happen in order to make those investments.
I think, Laura, one of the lessons here is, because it's also for TB and other airborne diseases, is the future of engineering and architecture in building infrastructure. We need to make it more environmentally friendly. It is just a must. Even my own organization, PAHO, is in a building that is very old, from the 1920s here in Washington, D.C., but it's not very environmentally friendly. I always tell my staff, when we're going to get back, we need to look into this, because, and I remember when I was based in Geneva, the new building of the Kofi Annan building where UNH is, and we had the Stop TB. One of the main issues in building that infrastructure was the environmental aspect, and making an open space and breathing space everywhere. So I think it's important, because this is always a factor in, if you look at prisons, of course, higher risk. Home care, also a higher risk, and senior people there. So there are certainly occupations that are, and historically, we don't need to talk about asbestos and cancer and lung cancer and so on. So I think it's important, and this is why we talk about other sectors, bringing in, when we think about building hospitals and infrastructure. Given the environmental determinants that we have so much to deal with in climate change today, so this is a vital issue.
Yeah, I don't have much to add in response to that. I think that is really on target, but I just wanted to add one small thing is I think when we talk about vaccine equity and how people are being vaccinated is something to really take seriously with occupation. For example, I am eligible now as an educator, although some people who are working on the front lines are not vaccinated yet. And, you know, what does that mean if my daughter who is going to school every day's teacher is vaccinated versus me who can teach virtually? And what does that mean? I think it's really hard to promote equity in that way through the ways in which we are vaccinating people. And it's also hard for people to get appointments. So how is that an equitable issue? And I really think that the vaccination, I've read some, and you know, Jeff can speak to this much more clearly than me, but I have read of some programs going into occupations and or occupational spaces, going into companies or wherever people are working and vaccinating on the ground. And I think that is so important, offering that in person rather than you need to take off work, you need to spend hours scouring the internet for an appointment, you know, you need to do these things because that is not equity. And that is creating extraordinary inequities in who's safe as we progress. And, you know, as Jeff said, we are not out of this, we're in the middle of it. And so, you know, that's been so concerning to see and reconcile.
Yeah, thank you. So we have a question about spirituality and how communities, spiritual groups, religious groups, how have they been involved in addressing some of the syndemic factors in COVID, in the COVID response, and do you see them playing a large role as we continue to work through this pandemic? And if there are examples from other diseases, I think the person who wrote the question would be interested in those as well.
I can just say briefly that I think that there are two sides. On the one hand, we're seeing some religious leaders getting vaccinated. We saw the Pope get vaccinated, really promote, although he did create some controversial comments as well. But we've seen a lot of promotion through religious communities of vaccination or caring for each other. On the other hand, we've seen extraordinary harm from religious communities, specifically white evangelicals, who have been used pro-Trump rhetoric to diminish the reality of the virus and of the threat to others. And that has created a lot of harm. So I think religious communities are powerful spaces to create, to promote good health and also cultivate conspiracy. So I think this is an important question and something that I think people will look at for a really long time. On what is the role of faith communities, faith leaders, and also this kind of role that Trump took as like as a messiah kind of perception within the U.S. And messaging and rumor and belief are so inbound in religion, especially in the United States. And so this is tricky, and I think it's not an easy question. So thank you for posing it.
And if I could just add on briefly, our experience here has been mixed as well. We have a faith-based community work group specifically for COVID-19. And many of these faith leaders have been great partners in getting messages out to their congregants from the get-go about how to stay safe and make good decisions to protect their health. And they endorsed virtual worship ceremonies rather than gathering. And on the other hand, we've had other faith-based leaders who have encouraged their followers to gather, continue to be indoors without masks, and we've had transmission in those settings, and many of those have been published by others as well. So it has been a mixed bag. I would like to just call out, in the context of syndemics and the opportunity to work with faith-based community. William Barber's Poor People's campaign. The fundamental priority on social justice for poor people, I think, is a major driver, will be a major driver, if successful, of better health. So there are plenty of opportunities, I think, for us to partner with faith-based leaders, but it hasn't been something that's been a major part of our public health work. And I think it's a really interesting suggestion to think more about.
Great, thank you so much. We have a lot of questions that are getting at the political angle and the need for more political engagement. And one of them starts with the principle that public health, as Jeff said, when there is a crisis, there's a temporary increase in funding for public health. It doesn't last. When public health works, people don't notice it because it's working. And then you can get a decline again. And so the question is, how can policymakers and legislators be encouraged to comprehend kind of the long-term need for investment at all these different levels to prevent future syndemics? And so I guess that's one question. And then relatedly, do you have advice about how to engage politicians in public health awareness better, and potentially conversely, how to help medical and public health experts be more effective in politics? That's kind of.
I could start there. That is a great question. I can tell you, I was just saying at the beginning that Latin America and the Caribbean is growing economically, but wealth is not well distributed. So guess what? PAHO recommends that countries in the region should invest at least 6% of the GDP public investment into health. And guess how many countries of the countries of the America on the entire continent are reaching that capacities? Only 7 countries. So they're still below on investment. Health investment is not attractive to our leaders. And that's what we need to, if we only focus in the technical part, it's not going to do the trick. There is this called political advocacy. It's critical to engage leaders, ministers, and it has to be constant, because ministers of health, presidents, and so on, they come for 4 or 5 years and then they go. Somebody else come with a new, I'm not talking about the US, it's a different thing, but the US also has its own challenges in terms of equality in access to health. And we do know that, but I'm not the most qualified to talk about that. You are, some of you, Jeff probably. So, but when you see countries that are growing economically, like, the ones like Mexico, Brazil, Dominican Republic, Argentina, and Argentina is one of them that is investing actually, and several other Central American countries that are not investing. They're growing economically, but it's easy to invest in military issues. It's easy to invest in things you can see and praise. Oh, what a beautiful monument, or what a beautiful sport thing. These are all good, but unless health is taking, and Emily said at some point, it's a political issue, unless it's taken seriously, and we all know the things that developed countries are education and health. If we have healthy people, then they can contribute and they can be put in society. So we are still very far behind. Hopefully, and the question is great, this is a wake-up call for this pandemic, for countries to, and the leaders to invest and in health, not only in pandemic preparedness. There is so much to do in cancer, in diabetes, in emerging infectious diseases, in food safety, food security. So we are still far away to go on that one, because the world is a global village. Borders, this pandemic don't respect borders. Even if one country, the US or UK, does it very well, they are not exempt of the next pandemic.
Yeah, absolutely. And I would just add that, our elected officials reflect the values of our society. And I think, we need to think of this also from the ground up and understanding, what we want to prioritize as a community and becoming more literate and educated about the importance of health and the determinants of health, what they are, what drives them, and then electing representatives who are scientifically literate and who reflect those priorities. To some degree, our elected officials, varying degrees, represent the views of their constituents. And I think we need to think of this holistically and not just about educating elected officials, but by electing officials who better represent the values of the community, who are more knowledgeable about health and science, and also whether there's a way to educate everyone about the importance of these issues and the economic value. I think this is another thing that elected officials are reluctant to do, is invest a lot of money in something that they won't see the returns on during their tenure as an elected official. People like to show their constituents what they've done for them concretely in a very short time frame. The electoral cycle is short, 2 to 4 years. So it's very hard to get people to make hard decisions about investing resources for something that's not going to pay off till they are long gone out of their office. But I think this is fundamentally a question about the values of our society.
Yeah, and just to piggyback on that, I think a lot of this comes down to the fragmentation of what public health is and what it does and what it can do, what public health officials can do in the country at a national level, and which is not actually a lot, and it's county by county. I think it's also state by state. There's really different regulations, and there's not a lot of federal leadership on what public health is and does. And I think that could potentially change. And that could change somewhat through like the public health core that Biden's put forth, or, just having more bodies around that are devoted to and working on public health. I mean, in my small ethnography I did in rural Iowa this summer, the only arsenal public health officials had without county supervisor support was messaging, and was like staying on message. And that is weak. That is not a strong, those aren't many tools to actually do what's needed. And I often have this conversation with my students that if at the founding of our country, we prioritize public health or medicine or healthcare like we did education, how people perceived the right to health would be so different, because so many people, because of our public health or our public education system, perceive education as a right and something we should provide. And that is cultural, but it's so structural. So if there are possibilities to use this pandemic as a way to restructure what power public health communities have and to identify the fragmentation and overcome some of it, I think it could be really powerful. Now, can we do that? Or do we have the political will to do that? I'm not sure. But I do think that some of the leadership that I've seen appointed would definitely be committed to it. So we'll see what kind of political power they have to restructure and reimagine what we can do.
Great, thank you very much. So we have a question that I think is relevant to where we're virtually meeting, which is at the National Academies of Sciences, Engineering, and Medicine. And one of the things that organization does best is bring together all the relevant knowledge on a subject and create a report, and they're really important reports. And one of the questions is, what do you think might be the value of a national sort of after action report after COVID-19? Is that even possible? Do you think that's something that would be valuable for the future?
Well, this is Jeff. Based on history, I can say it's possible. There have been multiple after action reports after all sorts of previous outbreaks and emerging infections. And I think it's absolutely necessary. I mean, and it will be happening. I know they're already in progress. So whoever asked the question, you're right on. You identified a need. And I think, there will be various levels of after action, various levels of government and local, state, national. There's so many issues here, ranging from supply chain and PPE and global and national health security, biosecurity, to all the issues that we're raising about determinants of health and underlying vulnerabilities in health and systems that can make our communities more resilient, countermeasures, testing, communication. I mean, there's so much to delve into in an after action report or after action reports. I think the bigger question for me is what will be done with them, because we've had after action reports after multiple past emerging infection events and health emergencies, and it's I think it's questionable that we've taken advantage of the recommendations and the findings. You can find many of them online, read some of them, and judge for yourself how successful we've been in implementing those recommendations. I can guarantee you, I recently pulled up an after action report my personal after action after the H1N1 outbreak. And much of this was done in collaboration with the National Academies. And I would say 85% of the things that I had identified as gaps during the H1N1 outbreak continue to be gaps and are going to be the same lessons learned and gaps identified during COVID. And I'm sure you can anticipate what many of them are.
Yeah, thank you. So we have a question about using the syndemic lens could that be helpful in making a case for treating public health as a matter of national security, of defense? And historically in the United States, that the bucket of money available for defense is much larger than the bucket available for public health. And do any of you have insights into whether that approach, and specifically a pandemic or a syndemic lens on that approach, might be productive in the future?
I think that's all. I don't know if that funding mechanism is the most, if we're talking, I mean, it might be. I don't know. I definitely think already it's been cultivated as a security problem of national security. That's already happened. Now, how that's funded, we'll see what happens with where that is situated. I mean, I know that they're starting to re-implement the global health security agenda, whatever that means, what that looks like. It will probably not be the same as it was with the Obama administration. Where will that sit? I know that Beth Cameron is leading the national health security is her position, but it's or bioweapon security or biological threats or something is her position. I'm not sure, but she's working on health security, global health security, pandemics preparedness. So that is already a problem that is considered a security problem. So does that work as in a syndemics framework? Traditionally, the idea of securitization is kind of a threat to equity in somewhat, because it takes away power from communities, and it those are often two kind of opposing viewpoints. But I do think that syndemics could create a strong foundation and a scientific argument for why we need to prioritize pandemics in funding. So I think that this is just like such a contested question, because by investing in security, you're also taking money away from horizontal kind of programming. So as we further silo, like anything that's considered a viral threat, all the money is going to pandemic preparedness. Well, that takes away money from other really fundamental prolonged issues like diabetes or many other infections that we could talk about. So I think that's a tricky thing. It will definitely be, and is already a central question of national security, pandemics. Now, using the syndemic framework, it could absolutely make a case. But what that does in the, I don't know. I think it's interesting. I'd like to know what the other panelists think. I definitely think you make the case, but again, it takes away from my ideas of investing in horizontal kind of approaches, so community-based approaches. I might have just cultivated more confusion because clearly I think it's a very challenging question because syndemics come from critical medical anthropology, which is really about community-based understanding and localizing and understanding differences from place to place. So when you think about security, it's very national level, high level thinking and investment, and not necessarily focused on community needs. So as deploying money in public health for a problem, yes, absolutely, but getting resources to respond to different community needs is a different question. I think I really confused people by my response because I think it's also confusing.
It's confusing.
I don't think you did actually. I think this is one of the main questions people ask between the funding of IHR core capacities and the funding of health system strengthening, because many people see it in disparate ways or separate from each other. And while there is a lot of advocacy, health system strengthening and core capacity of the IHR are basically essential public health functions. Yes, it is, but the funding doesn't go mostly to health system. It goes only vertically to security issues. So this is something that needs to be addressed if revision of the IHR, the global health agenda, is going to take place, because it is fundamental to strengthen health system. Even though there are vertical programs, the programs will not work if we don't have the drugs, diagnostic and commodities and vaccines at the first level of care, close to the community, where people don't have to walk hundreds of meters and kilometers. And we do know that happen in African settings where the next health post is really far away. So it's a very difficult question, but needs to be addressed because it could create more harm, and in fact, it has created harm than benefiting. And there are some people now saying health systems are getting weakened because of this issue. So it's interesting argument and question to food for thought.
So we just have time for one quick response to a final kind of future-looking question. And several people have asked, using a syndemic lens on COVID, what are some of the changes in public health interventions that you think or maybe hope will happen, as we're ending this pandemic and if it's ever over?
Well, I guess I'll start and let the experts follow up. A couple of things. This framework is very consistent with the already well-recognized social determinants of health framework that public health folks have been aware of and focusing on. So I think there's a lot of opportunity there to see what we can learn from this framework that will help us move that agenda forward and recognize, all those factors that we've discussed that drive health outcomes and inequities, and try and do better on those fronts. I'd also, just like to point out that, our nation's Healthy People 2030 overarching principles include things like promoting health and preventing disease in ways that encompass physical, mental health, and social health dimensions. And also achieving health and well-being requires eliminating health disparities, achieving health equity, and attaining health literacy. So there is some tacit, national endorsement for this general sort of framework. I think it's a question of communication. And Emily was saying how complicated it is. And it is complicated, but I think if we're going to be successful, we're going to need to make it more simple to communicate both to the public and to the policymakers.
Yeah, I would agree. And I think I can't say it any better than Jeff, but I would say that one of the most important things about the syndemic frame is really demonstrating how, so much money, especially through the NIH structure, through the government structure, is focused on outcomes. So if we want to, let's say there's a lot of money for diabetes, or there's a lot of money for HIV. HIV is the best example of a disease that's taken on a profoundly social experience, and how people have funded so much good work on mental health, on basically anything in global health for the last 20 years. If you want to get funded, you can say and HIV, which because of vertical money, vertical funding. And so the syndemic framework demonstrates how profound mental health counseling is for living with diabetes, or community gardens maybe, and shifting the narrative of what matters and what is an effective intervention, and providing money to support those efforts. There's just no way to ignore climate as we look forward. We can't have these conversations of politics or disease without talking about this little planet we live on. I mean, as we look forward, ecological climate policy, where we live and how we care for the planet, agriculture, thinking about the agricultural industry, what we're doing to our aquifers, what food we're producing and why, and how those structures continue to perpetuate a very damaging system to our future, to our children, to their children. So, really having these conversations and using the syndemic framework can demonstrate what interventions can make the biggest impact. There's always the challenge between policy interventions are hard to measure and tricky, like I was saying, it's hard to see, and it's complicated. Going to the doctor and getting a pill is very easy to see the impact it's kind of like therapy versus psychiatric meds, right? Or getting a Xanax rather than dealing with the root causes of your trauma, right? Those are two very different approaches, and you're going to feel some immediate relief by that Xanax, but you're never going to fix the root problem, and it's going to be chronic and persistent. So if we're going to get to the root problems of, the American experiment, why are we breaking? We need to deal with what's making us fracture and how we can confront these global, climate crises that are on our doorstep. So that's what I think a lot about. I think syndemics is one framework that enables us to make a scientific argument for why food policy matters.
Great, thank you. So let's see, Marcos, do you have a quick one? Okay, yeah, thanks. Yeah, I kind of pushed it long because there was so much to talk about climate and COVID. There is a webinar tomorrow at the National Academies tomorrow at 3 on the intersection of climate and COVID. So if people would like to join us for that, that should be a good conversation also. But I want to thank so much the speakers today, Emily Mendenhall, Marcos Espinal, Jeff Duchin, and it's been just a really, really insightful, important conversation. And to wrap up, I want to send it over to the co-chairs of this webinar and the series, Elizabeth Hermson and Rafael Obregon.
Yes, thank you, Laura, and thank you all the panelists for a great session. I think it was great. Thank you, Emily. Thank you, Jeff. Thank you, Marco. And thanks to you as well, Laura, for great facilitation. Obviously, I think we all have multiple takeaways. I think in the interest of time, I will not go through the many notes that I took, but certainly I think I would echo what Jeff said in terms of how syndemics, and certainly Emily's presentation was brilliant in terms of walking us through the key concepts and how it actually translates into specific realities. I think it's consistent with other frameworks that have been already put forward in the context of public health. But I think what's really important from my point of view is how it should help us change the way we think about disease and how we look at disease in a broader context, and how we look for responses that are actually more multidisciplinary and that take into account social and economic realities, disparities, inequalities, and so on. So I think it's a very important opportunity to actually broaden that perspective and take a more ecosystemic, socio-ecological lens to this. I also would like to just highlight how all the presenters spoke about the importance of community engagement and community-based interventions and solutions. I think we know many of them. Unfortunately, they have not been implemented at scale or not in a sustained manner. So I think it was another reminder of how we need to strengthen those elements without obviously losing sight of all the other interventions that Marco outlined in terms of obviously diagnostics, point of care, all of those elements that are part of the public health system. I think another point very important is really to avoid going into that fire and forget attitude towards public health and epidemics and pandemic response, or what Jeff said, Groundhog Day. We saw that during Ebola. Will this be an opportunity to really do something different and put in place the resources, the investments, and the political will actually to transform how we look at disease and epidemics and pandemics globally and at country level? And again, I could go on with other observations that I made, but I think the important point here is how we actually leverage these concepts and bring them into the broader public health sort of menu of approaches and lenses to actually improve how we respond to these challenges. So there's great potential certainly to actually strengthen how we look at these issues and provide more holistic responses. So before I just make a couple of final remarks and say a few words about, let me ask my co-chair, Elizabeth Hermsen, if she has any takeaway that she also would like to share.
Sure, thank you, Rafael. In the interest of time, I will just close with one key takeaway that I think we all have an increased recognition that social policies are really key health interventions. And I think that was just highlighted throughout the session today. So thank you to you, Rafael, the planning committee, and all the speakers, and I'll turn it back over to you, Rafael.
Yes, thank you, Elizabeth. And certainly that's another point that I had written down, how in the case of Paraguay, where I am at the moment, really, you may remember that at the beginning of the pandemic, Paraguay was a great example of how the country took action and imposed restrictions and interventions early on that actually helped contain the epidemic in the first phase of it. But afterwards, it was really hard to sustain those public health measures, precisely because of a lot of those social inequalities and disparities. And so I think it's a good example of how all these issues actually play out in a specific context. So just to bring things to a closing, let me just say that as Elizabeth mentioned at the beginning, we are working on the summer workshops, and along with the planning committee and the forum members, we have been looking at issues that we would like to discuss more in depth during the summer workshops. And the idea is to have a series of webinars, potentially one in-person meeting where we will look at different issues. And let me just give you a very quick rundown of some of the critical points we're looking at. For instance, the impact of COVID-19 on other healthcare issues, TB, HIV, malaria, diabetes, many other issues that certainly have been impacted by the COVID-19 pandemic. What can we learn from organizational failures? How do we prevent making the same mistakes next time? But also highlighting successes, especially in Africa and Asia, where we know there have been very interesting responses. What have we learned in terms of public health messaging and communications? And that was raised by some of the presenters. Again, looking at the social inequalities that COVID-19 has enhanced, exacerbated in many contexts. Also looking at that issue of panic and then forget cycle, looking at the balance between science and politics, looking at more buy-in and investments from government leadership, issues of funding, which also were raised today, and moving beyond the short-term focus and really looking at how we put in place strong, robust public health systems that are better prepared to prevent and respond in the future. issues related to infrastructure, travel regulations, transportations, the impact on the private sector and the role they play in outbreak preparedness and response. And then some elements that some of the members actually feel strongly about in terms of looking at, for instance, the long-term effect of school closures, which we know has been a big issue in most countries or all countries, and the impact on mental health, especially on childhood development, adolescents, but certainly adults as well. So a range of topics that we are looking at, and over the next few weeks, we're going to narrow down these topics, and we'll come back to you with more information about the series of webinars for the summer. So we hope that you will join us again at that point. So let me close by, again, thanking the leadership of the forum, Peter Daszak, who is our chair, as well as Ken Kester and Rima Kabaz, our vice chairs, the forum staff, Julie Pavlin, Charlie Minikushi, Claire Biffle, and Julie Liao for the great work that they do, as usual, as always, to our sponsors for their support. Without it, this would not be possible. But more importantly, to all of you who've joined this event today, thank you for engaging, for participating, for your comments and questions. And we really look forward to seeing you in the summer. And finally, thank you to my co-chair, Elizabeth. It was great working together on this event, as well as with the planning committee. And so with that, I will adjourn the meeting and look forward to seeing you soon. Thank you all.